So speech and language, another MLA presentation lecture, lots and lots of causes of speech and language problems. I'm not going to talk about specific illnesses per se, but just about the processes and pathways that are involved in speech and language problems. So just a quick overview of how we generate speech in the human brain and via our oropharynx, throat and vocal cords. We'll talk about what dysphasia is as opposed to dysarthria and dysphonia, and how to identify what the problem is in terms of speech generation, and I'll touch on the conditions that can affect this. So speech is really, really complicated. It was one of the last functions to evolve in human beings, and we have to remember that it is in part a transition between thought. So thought needs to be converted into muscular contractions of the throat, the oropharynx, the tongue, the larynx, and modulation of the vocal cords to allow airflow to be modulated to allow recognizable speech and generation of sound. So we're going into brain, spinal cord, and more than 100 muscles that must be carefully coordinated to allow speech, which is pretty impressive. Consonants generally are more challenging than vowels. So we often see things like pers and ters and sers. They tend to be more easily affected if there's dysfunction, particularly in the muscular generation of speech. So starting off with dysphasia. So quite often when someone has a speech problem or a language problem, what I want to know is it a problem with the transference, the generation of speech within the brain? Is it a problem with the muscles that allow the sound to be generated, or is it a problem with the flow of air through the throat? So dysphasia is a problem with either understanding language and being receiving it, or generating or producing language. Receptive dysphasia and aphasia is where there is nothing. So dysphasia is abnormal, aphasia is that there is just nothing, there is no speech generated. So receptive dysphasia, this is due to a problem in the area known as Wernicke's area or Wernicke's region. So people with damage in this area can speak fluently, but there is no content. It's nonsense, so it's fluent nonsense. And when you speak to them, their receiving area, so if you imagine a walkie-talkie, what they receive cannot be processed and understood as recognizable language. So you'll hear somebody with Wernicke's dysphasia or Wernicke's aphasia, and it's just an absolute word salad of nonsense words. And you'll then speak, you test understanding by giving a command. So would you be able to touch my hand, touch your head and touch the bed? And they'll look at you in confusion. They have no idea what you're saying. They are unable to take the words that you've spoken and convert them in their brains to recognizable understanding. So they cannot obey verbal commands. With motor or Broca's aphasia or dysphasia, it's very painful to speak to these patients. They understand what you're saying, so their receptive function is normal. You give them a 3-stage command, they do it. They understand what you're saying. They have an inability in response to generate recognizable language. So their thoughts are intact. The thoughts go into Broca's area. I want to say, yes, I can understand what you're saying. And they'll go, yes. And it's really painful and effortful is what we describe. That area of the brain that converts thought into commands to produce the speech is damaged. And the understanding is retained. So this is very difficult for patients, particularly after they've had a stroke, which is the most common and acute form of this sort of damage. Patients get horribly depressed and frustrated because they understand but they cannot communicate, and it's very distressing for family members as well. In extensive lesions that affect both Wernicke and Broca's area, there is an inability to generate speech and an inability to understand. And we call that global dysphasia or global aphasia. And everyone is aware of this sort of issue happening in somebody who's had an acute stroke, but it can also happen in forms of neurodegenerative disorders, so frontotemporal dementias. The typical one within the frontotemporal dementias is called progressive non-fluent aphasia, which is probably the disorder that Bruce Willis has, if anyone knows Bruce Willis. And if you see some of his later films, you can see that it's really effortful for him to speak. And I think he was teased quite a lot by the Academy, and that was the early stage of progressive non-fluent aphasia. He was unable to convert what he wanted to say into recognisable speech. Alzheimer's dementia, you also get this sort of problems in the late stages of disease. And if you have a slowly evolving problem like this, you would think of a structural lesion in that area like a tumour. Now, as opposed to dysarthria, which is the reduced ability to coordinate the muscular movements to generate speech. So there's no problem with understanding, there's no problem with converting thoughts into speech, but the muscles of articulation aren't working properly. Slurred speech is a dysarthric speech. And like I said before, more than 100 muscles need to be coordinated to produce the different sounds and movements to give human speech. We typically ask patients to say things like British Constitution or baby hippopotamus, lots and lots of changing consonants. I have a colleague that always used to try and cram every consonant into a sound, so putuka, putuka, putuka. And if somebody can do that confidently, they don't have dysarthria. So I think of dysarthria as coming in three types or three flavours. So one is cerebellar or ataxic dysarthria. So we think of cerebellar ataxia as being unsteady with slurred speech, maybe abnormal eye movements. And you can get cerebellar dysfunction from lots of different things, but the most common and temporary form of cerebellar ataxia is being drunk. So alcohol temporarily affects the cerebellum, and drunk people have slurred speech. That is the sort of slurring speech that you get from ataxic dysarthria. We sometimes call it scanning or staccato dysarthria. People get sort of loud and then they get quiet and then they sort of slur over things. When you think of ataxic dysarthria or cerebellar dysarthria, think about how people sound when they've drunk too much alcohol. The second is a spastic dysarthria. So that's upper motor neuron. The tongue is very tight and the tongue is very stiff. And we call that also pseudobulbar. And you can see that in lots of different brain disorders that affecting the brainstem particularly. You can get it in stroke, you can get it in motor neuron disease particularly. People with this have a brisk jaw jerk, and they often have emotional lability. So it's tied in closely with emotional control. So people will cry or laugh or become angry very, very readily. And we sometimes call this hot potato speech, because when you have something that's too hot in your mouth, you kind of stiffen all the structures in your mouth to avoid them getting burnt. So if you stiffen your tongue in your mouth and then sort of try and talk around a very stiff, immobile tongue, that's what a spastic dysarthria sounds like. And people with a stiff, spastic tongue will struggle to stick it out, and it looks very tight and small in the mouth. And a lower motor neuron variant of that, where people have a very floppy tongue that's weak and often fasciculating, will give you more of this sort of sound. So if you let the tongue just lie flat in the mouth, that sounds much more like a flaccid dysarthria. And you can see that in neuromuscular disorders where you have general muscle weakness. So things like Guillain-Barré, myasthenia gravis, for example. But this can also happen in motor neuron disease as well. So you can have an upper motor neuron tongue weakness or a lower motor neuron tongue weakness in motor neuron disease. So that's dysarthria. And dysphonia is problems with the vocal cords, allowing the flow of normal air through the glottis to sort of modulate the sound, because we obviously need the thoughts to be converted into words, we need the muscles to then do everything they need to do to generate the sound, and then that air needs to flow in the correct way to generate the vibrations in the air to produce speech. And dysphonia is just disruption of the airflow. So as neurologists, we worry about vocal cord paralysis. And if you get vocal cord paralysis, the speech is very quiet and breathy. And if you ask somebody to cough with vocal cord paralysis, it's often called bovine cough or a cow cough. People sort of they can't cough properly because they can't control and modulate the airflow correctly. Sometimes there's hoarseness, and And I suppose you can get dysphonia if you get really bad laryngitis. That's a temporary and benign dysphonia. If you get damage to your long recurrent laryngeal nerve from surgery, a chest drain, that sort of thing, that can cause paralysis of the vocal cords. It can also be caused by a high lung cancer, so a high bronchial carcinoma, or a big swelling in the aortic arch, like an aneurysm. Also, obviously, the laryngeal muscles get weak if there's generalized muscle weakness, and I always use the example of GBS or myasthenia. But in a smoker with a hoarse voice and breathy abnormal voice that's quiet, always think about head and neck tumours or lung cancers. So just a summary of speech and language. The production of speech is super complex. There are lots of moving parts, literally lots of moving parts. And as well as sort of converting thought, interfacing thought into activating muscle, there are hundreds sort of coordinated muscles or more, and then the flow of air through the vocal cords to produce that speech. It's your job as a doctor to understand, is this a problem with generation of speech at the level of the brain, understanding speech, i.e. receptive? Is it dysarthria because the muscles of articulation aren't working or are weak? Or is it sort of a hoarse, breathy voice because the vocal cords aren't working properly, dysphonia? And I'm going to say it again, you need to talk to patients. You need to talk to them and you need to try and understand from not only from what they say, from the history, but literally the quality of their speech as to what level that is, and then look at the different types of condition that could be causing that. Thank you.